Sean, thank you very much for joining me today. Welcome to the Crooked Smile podcast. It is your weekend off, as you've just told me. What's that look like? And you only getting every second weekend off.
It's busy. It's one of those things that you get quite used to as a doctor, as a medical person. It's unfortunately a fairly standard roster in the world of surgery, in that you sort of work the week and then you have alternate weekends where you share with someone else. But it's harder for, I think, my family than it is for me because
because you're kind of there.
You're absent a lot of the time, and when you can finally get time off, you're exhausted and trying to recover.
What's the longest shift you've ever had?
It depends on a lot of different things. I've certainly found over the last few years it can become quite common to sort of be at the hospital at work all day, and then if you're on call, be there all night, and then the whole following day, which gets pretty tiring.
Especially with the type of work you're doing.
Yeah, it gets very tiring, but I think that the better thing is this is certainly obviously something that was very common, throughout many years of people training and learning to be surgeons, but it's gotten much better over the last decade or so, where we have a lot more recognition that people need breaks, need time off, and we all, I think, as surgeons, take a lot better care of each other to ensure that when someone's had a long shift or a long night or a tough day, that we try and cover for each other and let them have that break that they need.
Because I can only imagine when you're sleep deprived, that's like the worst thing possible if you're trying to save someone's life.
It's hard. It's one of those things that you kind of have to make sure you're focused when you're in the zone, so to speak. What I have told people in the past is actually a lot of the operating that you may do as a surgeon is actually quite easy to do, even when you are a little bit tired. But it's a lot of the decision making and the communication that happens in between operations that are very difficult to do when you're very tired.
Yeah, okay. Because I've recently, and we were just talking about this off camera, I've recently watched the PITT on HBO, where it's like the American ER and like all the stuff that comes through and they deal with. And I know it's like all the worst things that could happen in a day happening at once. You get to see it all, but it's like how similar the stuff that happens there to the stuff that you're seeing and having to operate on. Like, is it pretty similar?
I think, and we have talked about this at work and with our colleagues and things like that, but I think any individual case or scenario that you see at the PITT is probably recognisable to anyone who works in healthcare. It would be very unusual to have all of those things happening at once. It's kind of like a best of everyone's entire career.
Highlight reel.
In supposedly in one 24-hour period. But I think everything on that show, despite it being, quite dramatised and sensationalised, is the reality. We see patients with those problems all the time. And every scenario there is probably familiar, and it's the medicine there is actually pretty good. And the way that hospital in the PITT works and the way the doctors and the staff interact with each other is probably actually quite realistic.
Yeah, right.
Yeah.
Right. Because my girlfriend works in OT and she's done a bunch of stuff. She does outpatient stuff at RPH and at Charlie's, and she was saying she watched the first 4 episodes and was like, I'm not watching any more of this, I don't like it. And her reasoning was it's not realistic because they're wearing long sleeves and they've got jewellery on, and those two things wouldn't happen in an ER. And I'm like, oh, okay, so I wouldn't even know that.
Yeah, I think it is obviously a bit dramatised and sensationalised, but I will say, in the heat of the moment, I have seen things that do happen. I've seen a trauma surgeon, putting on a gown and operating on someone essentially in his suit with some gloves on when the need arises. So it does happen, but, we do try to, obviously abide by, sterility and cleanliness, and, there's a lot of rules and things like that. But yeah, the idea that we're just sort of doing what we want anytime we want is not true.
It'd be pretty full on, right, being a trauma surgeon and seeing the stuff you see. Are you desensitized to it now? Has it taken a while, or do you still see stuff that is pretty wow, okay?
I think you certainly, I wouldn't say desensitized, because that sort of implies that, these patients and the things that we see doesn't have an effect on you. But you sort of, you have a coping strategy, and you also have the support of your family and co-workers. And I think the big difference between sometimes what we do in a busy trauma centre is we have the support of our colleagues that we can sit down afterwards and talk about,
Okay.
stressful times, stressful experiences, difficult cases, and have that support from your colleagues and co-workers. And I think what that highlights is that sometimes when these injuries happen elsewhere, like outside of our environment, how tough that must be for other people. Doctors, nurses in really rural and regional centres who may only see one bad accident in their entire career, and they have to deal with that and process that without the support of having seen it a lot and having a really robust network of people around them to help them deal with that. But you do separate yourself a little bit from the situation in the moment. You sort of tend to focus on it as this is a problem that we're trying to fix. And sometimes the patient or the person gets a little bit lost in that you sort of can't have a really big overview of the person that you're trying to save. You've got a bunch of problems that you're trying to fix, but you can't necessarily distract yourself with, what that sort of emotionally means for the patient and the family members.
Is there family members sometimes in the room while you're operating?
Rarely in the room. So it gets pretty busy and pretty full on in the emergency department. And we try to keep the families a little bit separate from that, just sometimes from a pure physical space point of view. Obviously, a lot of the time things can be very distressing for family members if their family, their loved ones are very sick or very injured. We do try and keep the family members updated very regularly with what's going on, and we spend a lot of time talking to family members either on the phone or in person. But it's sort of rare that the family members are present when we're doing things. And I guess the reality is a lot of family members, the operating theatre is kind of its own very separate place where it's, family members really can't be. So we do sort of have a bit of a separation, but often, family members in the initial point of time, they're coming into the emergency department with their family sometimes. And we have, lots of our nurses and social workers who sort of help and sort of, keep the family somewhere safe and updated without being right in the middle of it.
Yeah, okay. How long have you been a trauma surgeon for?
So I'm technically still training to be a trauma surgeon. So it's a long, fairly complex pathway. So we go to medical school to become doctors. So that's university. I was at medical school for 7 years, or university for 7 years. Once you finish medical school, that's when you sort of become a doctor and you work as an intern. That's the little junior
residency?
Doctors. So it's a different system. So residency, as on the PITT, you see in the medical dramas, American system, they tend to finish their medical school and they go sort of straight into a streamlined pathway. So a residency in a certain field of medicine. In Australia, we do it slightly differently, similar to in like England, the UK, in that you spend a period of time as a junior doctor without being in a particular speciality. So our interns, as an intern, you still have to cover the breadth of medicine. So you might spend some time with surgical units, you might spend some time with medical units, you might spend some time in the emergency department. And so that's a year where you sort of have to still play the field, so to speak. And then as a junior doctor, you're often employed by a hospital or a health service to work in varying departments. And that can somewhat be streamlined into sort of medical or surgical.
And that's kind of where you pick what you want to do?
That's kind of where you pick what you want to do. So I did my internship and then I did 3 years as what we call a resident medical officer, but over East they sometimes call it a house officer or an SHO. And then I did, goodness, now I have to think, 3 years as a what we call a service registrar or an unaccredited registrar. So that's working in a field without sort of being in a dedicated training program. And then I did another 4 years training to be a surgeon, a general surgeon.
And where are you at now?
So you finish your general surgery program, you do some very difficult exams, and then you become a fellow. So you're a fellow of the Australian College of Surgeons. And I've done a fellowship in emergency general surgery, and now I'm doing another 2 years fellowship in trauma surgery.
So you're a doctor?
Yes.
Sorry.
It's very complicated. So I finished high school back in the early 2000s. I started medical school in 2005. I graduated medical school in 2011, and then I've been essentially training to be a surgeon
Ever
in
since?
various ways since.
Yeah, okay. And what makes you decide to want to do that?
It's tough. I think most people, that's not true. I think a lot of people have an idea of what they want to do when they finish medical school, but often it's, many years working in hospitals and things before you actually make a really clear decision. It's very difficult to sort of get into a lot of these specialty training programs. So that's often a really big barrier for a lot of people, that they decide they want to be a surgeon of some kind, and they can't sort of meet the criteria to start training.
And the criteria is just qualifications?
Some of it's qualifications, some of it's experience, some of it's things like research and publications and courses. But it's very competitive, and they have hundreds of applicants a year nationally for what might amount to 30 or 40 spots.
Yeah, for the fellow, is it?
For training to be a surgeon, and then when you finished your training, that tends to be the biggest barrier. But there's also sort of quite a lot of competition for more specialty training. So you can specialise as a general surgeon. You can specialise in things like bowel surgery, or breast surgery, or endocrine sort of surgery on people's thyroids. And trauma surgery is one of those sort of areas of speciality that you can go into if you choose.
So it's almost like you have the path of all these people that's slowly being weeded out until you get the trauma surgeon. So for how many trauma surgeons there are, how many doctors do you think didn't quite get there that were trying to?
I think it's hard. Trauma surgery as its own individual thing, I think, is relatively new and recent and niche. So I think, if we go back 10 years, a lot of what was trauma surgeons were people who have just sort of gravitated to that area of medicine without necessarily being a formal training process.
Yeah, okay.
I don't think there's many people in Australia who would call themselves trauma surgeons without anything else. So most of the trauma surgeons, all of the trauma surgeons at Royal Perth Hospital are all general surgeons. But there's people who would sort of call themselves trauma surgeons across Australia who might be vascular surgeons or orthopedic surgeons.
So when we say trauma surgeon, what type of surgery is that meaning?
It's tough, right? So, I think it's almost like a misnomer, because a lot of trauma surgery, as we would say, it doesn't actually involve surgery at all. So a lot of our trauma patients who come as major traumas to Royal Perth Hospital might not actually get an operation while they're in hospital. And a lot of the patients we look after as trauma surgeons might not get operated on by us. They might get operated on by the orthopedic surgeons or the neurosurgeons. So we really, our trauma unit is more of a managing patients with trauma rather than always operating on patients with trauma. But as general surgeons, we tend to do any operations on the abdomen that need doing, and sometimes the chest as well. But I think mostly our role is sort of meeting these patients when they first come into the emergency department, and sometimes initiating life-saving surgical management.
Until they can get the specialist.
Until they're at a stable position that, their other issues can be addressed, whether that's fractured bones or things like that.
Yeah, right. That's pretty full on. Just not even the job itself, but the process to getting the job. I didn't realize there's so much weeding out once you are actually a doctor and you're going through all of that.
I think so. It's something that you don't necessarily think about when you're here, but it's something that's been encouraged for me to think about by sort of my mentors and things like that, is actually I'm a long way down the track now. And over the years, by whatever means, whether it's skill, luck, coincidence, hard work, I found myself, very far down the track and sort of very specialized and, quite knowledgeable in my area of expertise.
Yeah, okay.
But when you're sort of working your way there, it doesn't feel like that. It just kind of feels like you're going to work and doing the best you can do every day.
You don't realize the momentum you're building until you're out of it.
Yeah,
That's
exactly.
like the big thing about momentum. It's a double-edged sword because you don't want to be out of it. But to be able to like have the kind of the perspective to look back on it, you're not going to realize in the moment.
Yeah, yeah.
It's like, I've got a million questions. I don't even know where to start. It's like, I can start with a very meta question if you'd like.
Of course.
What's it like saving lives?
It's great. I mean, no one can argue that obviously that's what you want to do as a doctor, as a health professional. Like you want to make a real big difference. I think it's very rare for a lot of us as doctors and people who work in healthcare to sort of be able to point to one thing and say, I did this thing and that was the difference between this patient living and dying.
It's a collective effort.
It's a joint effort, and it's hard sometimes to think that, well, if I hadn't done that one thing, like someone else wouldn't have done it for me. But certainly,
But you're still the one doing it, I guess.
yeah, certainly, as I get sort of more further down my pathway and more senior, I sort of am amassing a collection of people that I can genuinely feel like I can point to and say, well, like, I think that was something that I did that saved that person's life or made, not necessarily saved their life, but also just made a huge difference to their future that maybe they wouldn't have had if I hadn't been the one who was there at the time.
Is that, and this is getting straight into the kind of the gravy of the conversation, the meat of the convo, but it's like, is that why you do it?
I think so. I mean, there's a lot of people who would say that surgeons have got a big ego. I think part of that is because surgery is one of those things that you're doing something very physical, very tactile, and that's the thing that might save someone's life or cure someone of a disease. And I think that's a lot of the reason that probably a lot of surgeons get into surgery, because it's very satisfying to be able to say, here's a problem.
Instant gratification.
I'm going to fix the problem and, cure the disease or fix your symptoms, which is very gratifying and very, very satisfying. As to sort of my pathway in general surgery, I think it's one of those things that as you go along, you just find that you're good at one particular thing and you tend to keep gravitating to the things that you're good at and the things that you enjoy. And this is sort of where I found myself after, 15 years of being a doctor.
Yeah, okay. And then in terms of like stress on the job, like you've just been called down to the ER, there's someone's got abdominal wounds or something like that you've got to operate on. Like, how do you just like keep a cool head to like be present in focusing what you need to focus on to be able to save this person's life without like thinking, oh shit, this person's dying, I've got to do this, otherwise they're going to die?
I think sometimes my job now in trauma surgery is a lot easier than it used to be, because you can very clearly determine what your biggest priority is.
In terms of like what to address first.
Yeah, or if you've got this one patient who's very sick and is imminently dying, then that's your highest priority. And you can kind of justify to yourself putting everything else to the side.
Like
for
the
now.
other patients.
Yeah, other patients, paperwork, meetings. You can just say, I can't do that now. I've got something else that's more important. I'm doing that, and give that your full attention. And as I said, luckily, the thing about where I'm working and what we're doing now is we've got such a great team that, as things get busier and more intense, you've got more and more people around you who come and help out and, really take the burden off you.
But like in the moment of it, like what do you do to keep a cool head? Because like you can give all the credit to everyone else, but at the end of the day, you're the one operating then and there. And it's like, you've got to keep your shit together to like make sure that you're doing the right thing. And like and I'm not a surgeon, but if you're slicing in the right spot, you're not cutting too deep or like whatever it is. Like,
part of that goes back to the training, right? You've said it's really long training process, and that's the idea of that is it gives you the knowledge, the information, the the power, and then when you're in the heat of the moment, you rely back on that knowledge. So even if it's something that you've never done before, never seen before, you know that it's the right thing to do. And that's, I guess, the important is to have that somewhat certainty of like, this is the right thing to do in this moment, and knowing that I'm able to do it and to get on and do it.
I guess another thing, and this is from watching the PITT, it's like you got to diagnose like super quickly in an intense situation exactly what's wrong to be able to even start doing what we're talking about right now. And it's like that process of like diagnosing, like you still see new stuff every day that you've never seen before. And it's like where do you go to when you're like in that situation?
Yeah, I mean, that is 100%, I guess, the crux of the whole problem is being able to diagnose and treat like on the fly. And, you know, a lot of it is experience and practice and preparation. And that's, I guess, the whole point of what we're teaching, and the whole point, I think, of this process of learning how to be a trauma surgeon and doing trauma fellowships is to sort of be able to recognize things that happen and things that go wrong so that you can sort of jump to that process easier and quicker. I will say that a lot of the things like the medical TV shows in the PITT, they're sped up, right? So it's rare, but it does happen. You usually do have a little bit of time to think. It's not like you're having to make split-second decisions every day, every moment of every day. But there are times where you do have to make a split-second decision. And I guess, you know, that's what feeds into all of our preparation. You know, when we're thinking about patients and when we get notifications that patients are coming, we're already thinking about, right, what could be wrong with this person and how are we going to test that hypothesis, and then what are we going to do if it's true. And so some of it is about treating things before you even know that it's there. So like saying, well, this problem might kill this person, so we're going to just treat for that straight away, no matter what. And some of it is, I guess, being able to get the tests and investigations that you need as quick as possible so that you can jump in and do what you need to do.
Yeah, okay. Oh, and a tough question. I've got a tough question. How do you deal with when it doesn't all go right and it goes wrong?
Yeah, I think that it's a good question because, I mean, it's obviously something that we do deal with.
And it's going to happen.
And it happens. And I think the trick, and, you know, I tell people who ask this, because we get asked this question a lot, you know, the trick to it is, I guess, being confident enough in your team and your abilities to know that even if things didn't go well, so if someone dies, that we as a team did everything that we could and provided the best possible care for this person. And so that way you can at least sleep soundly in saying that, you know, even this person died, we did everything that we could. And that's all you can do. You know, you can't turn back time or reverse the clock or stop people from getting injured, but you can give them the best treatment possible.
This is like in the PITT, and it's watching the guy Robbie that leads it all, and then when he has to, like, a girl that drowns in a pool comes in and dies, and you're like, he's addressing her. It's like sometimes you just can't forget, and like with processing it and stuff, sometimes it's just gonna like stick with you. It's like, how do you deal with that in your personal life outside of it?
I think I'm very lucky in that obviously I've got a lot of family who support me. My wife is also medical, so she's got a little bit more insight than maybe the layperson would have on the street about sort of what my job entails and what it's like being a doctor. And she's a phenomenal support person for me. And again, having your colleagues and your friends and your family who sort of know that you deal with a tough job and you deal with tough situations, and just being available to support when things are not going well. And, you know, you have bad days, you have bad weeks where, you know, nothing seems to be going right and everything seems to be going wrong. But again, you know, the bad cases, they do stick with you, and not necessarily for the reasons that people think. You know, it's not to do with the severity of the injury and things like that, but it's often due to the social situation of that person. So, you know, certainly me as a young father or a father to young children, you know, if I see another father who has young children who comes in and, you know, has a bad outcome, that's sort of a little bit more punishing for me because I sort of imagine myself in that situation and my family in that situation, and think about what my family would feel like if I was injured or if I died or was permanently disabled from an accident. So it's tough, I think. There's no one single answer to how you deal with it, but having a good support network is, I think, completely essential. And again, that's what it's nice working in a big unit of trauma surgeons who have been there. They've seen all of these things before, and they sort of are very good at supporting us and looking after us as we train.
Because you think, the hardest part about it is like getting there, like with the qualifications and becoming a doctor in the first place. But obviously, it's like the hardest part is actually dealing with that in the job. It's not all the tests you have to do and exams, but it's the emotional side as a byproduct.
Absolutely. And it's very hard to forget that along the way, because you do get very wrapped up in what I need to do to pass my exams, to, get through this week, get forms signed. But yeah, every now and again something happens and you kind of almost forget that you're dealing with people's lives in your day-to-day practice. But I think it's a very important thing to sort of be aware of. And we try and teach our staff and our junior doctors that, your care of these people does make a difference. Like, everyone's vital.
Yeah. What's the most common sort of thing you see in treat?
I've got some statistics in my brain actually that I looked up.
Fire them out.
Before I came. So Royal Perth Hospital, that's where I work, the trauma unit there. We are one of the biggest trauma units in the country. And that's partly because of the idiosyncrasies of Western Australia, right? It's a huge geographical area, and you can't put a major trauma unit in every hospital across a state. So in Western Australia, it's all been centralised to Royal Perth Hospital. So we are the major trauma unit for the entire state. And that means that most major trauma in the entire state, from, down in Albany all the way up to Kununurra, eventually comes through Royal Perth Hospital. So we see about 1,500 major traumas in a year, which doesn't sound like a lot, but it's, 5 major traumas a day and probably quite a few minor traumas as well.
So a lot of it's flown in.
A lot of it's flown in. Yeah, about a third of our patients are transferred from regional areas, and probably another third have come from an area in the metropolitan that wouldn't normally come to Royal Perth if it wasn't for the trauma unit there.
Yeah, okay. And then like in terms of the stuff, I guess if it's regional, it's going to be like farming accidents and that sort of thing? Car accidents?
Yeah. So out of those 1,500 patients, about 500 or so of them are road accidents in various forms, whether that's cars, motorbikes, bicycles even.
Do you find it happens a lot more during the day or night?
It depends. So a lot of I think you can look at the statistics over time, but you sort of have this little peaks during the day. So like rush hour times, you tend to get sort of more minor accidents that might happen as people are sort of navigating traffic. And then in the evenings and the nights, you might get more people who have been speeding or out drinking and things like that. And then, the regional rural accidents, they come any time of the day. But they often take quite a while to get to us, which, is pretty tough for the patients. So that's about a third of what we see as car accidents. And actually about another third is people falling, whether that's people falling off roofs or ladders and things like that. Or it can be something as simple as an older patient who's fallen like in the bathroom, or even just, fallen getting out of bed.
And broken their hip or something.
And broken their ribs and hips and things like that.
Yeah, okay.
And then there's another third of patients who are sort of, I guess, miscellaneous. And probably a lot of them involve people like sporting injuries. So
any footy players come through?
There's been quite a few footy and rugby players I think have come through Royal Perth at one time or another. And, violence is another one. So whether it's, assaults or domestic violence, sometimes unfortunately we get those kind of patients. And then there's a whole range of others that would come into that MISC category, which is, I think, more your industrial accidents and your farming accidents sometimes would be in that category. And probably a lot of things that that might have been on a road, like bicycles, mountain biking, things like that. We see quite a few of them.
Oh, you wouldn't be
depending on the day.
squeamish, would you?
It's hard. I mean, some of the injuries, like the range of injuries are wide and like they can be very minor, but still, pretty major for the person.
Are you squeamish with yourself, but no one else? Or are you just not squeamish? Like for me, I'm kind of okay at seeing it. I hate needles. Sometimes I hate watching needles in other people. But like if I see myself with a needle, I'm gone. I got to look away.
I don't like getting blood tests myself, but yeah, I don't really have any squeamishness in putting needles in other people anymore. But broken bones are often, can be a bit,
Do you get a lot of open wounds come in?
Lots of wounds.
And then like how do you, I guess you say desensitizing is not the right word. So how do you get used to that?
I think there's always certain things that certain people aren't going to enjoy. And I think if you were someone who was squeamish about wounds and blood, you probably would never find yourself working in an emergency department or an operating theatre. So I think those people select themselves out of that environment. Having said that, there's always still some things that can really sort of make you a bit squeamish.
Can you say any, or is it too?
Oh, absolutely. I mean, I was helping someone had a really nasty broken bone the other day, and I was helping, you got to straighten it out so that it's in the right alignment, and I was helping to do that, and that made me feel quite woozy, trying to pop a bone back into place.
Was that like a hip?
It was a tibia. It was someone's lower leg that was really badly broken. We got to realign it to restore the blood flow to the person's foot.
So they don't lose it.
Yeah. Normally we would get our orthopedic surgeons to help us out with that, but this was enough of an emergency that we just decided to do it straight away without them there. And so I wouldn't normally be pushing on broken bones, but in this situation we decided it was worthwhile doing sooner rather than later.
Oh, and then like the open wound stuff, like, and there's blood everywhere and stuff. How do you, like, is that a bit graphic? That can get graphic.
It can get really graphic. I think the difficulty, I mean, certainly I can't speak for everyone, but the difficulty I find is if you get in your own head too much and start imagining it as your body, that's when it starts becoming really hard to manage. But if you manage to detach yourself as like, this is not my arm, or it's not this person's arm, it's just an arm that needs fixing, it's obviously a lot easier to do.
I know this sounds weird, but I hope you'd be able to like understand what I'm saying. Do you kind of like in your head, because you're doing all of these all the time and stuff, have a game of kind of like, oh, what ones you hope for that are like easy to do and fix, whereas like instead of the less complicated ones? Like, do you have any, it sounds really bad, but
any favorites?
Do you have any favorites where you're like, I know what to do here, let's just get it done?
I don't think so. I think certainly when I was working, in the general surgery field, like you always hope for a nice, easy or quick or like satisfying operation. But I guess working in trauma where we're not actually doing that many operations, it says really all you're actually hoping for is to not have to do any work.
Yeah, right.
It's like, I've got enough work, I've got enough paperwork. I hope that no one gets injured today. Like, I don't think any of us are really hoping for an injury to come in. But certainly back in the normal general surgical world, like sometimes you can sort of talk yourself into like, I'm really looking forward to doing a satisfying hernia repair or gallbladder operation or appendix operation.
Yeah, right.
That's certainly, I can understand that. But the injuries, not so much.
The non-sexy side of things, the paperwork, how often's that?
Every day. I think any health professional can recognise that we do a lot of paperwork. We spend a lot of time looking after patients after their injuries have happened as well. And that comes with a lot of paperwork, insurance forms, medical forms, legal documents, so police statements and those kind of paperwork. And, we also have a pretty robust system where we look back at all the patients who have come into hospital and examine their cases and figure out if there was anything that could have been done better. So you're doing lots of audits and preparation for, meetings and things like that. So it can get, very busy when you are working hard and you realize, I've got to prepare for that meeting tomorrow. So spend a late night sort of making PowerPoint slides to present to the hospital committee and things like that.
Do you do night shifts as well? You do it all now, or you've kind of got a set Monday?
We do on-call rosters, so we take it in turns between, all of the surgeons and us as fellows to basically be on call. So at the moment, sort of we have 3 surgical fellows, so 3 people sort of at the same level as myself. And so we have someone on sort of a morning shift and someone on an afternoon shift. And then
so you're off right now?
I'm off right now. There's one of the fellows is in the hospital right now and he's on call over the weekend. So he'll be
just living there for the weekend?
Not necessarily living there, but if anything happens and they need him, he'll be back in the hospital.
Have you ever been called when you're in the middle of like something super important, had to go?
Yes. I guess you plan to not be doing anything super important.
But it happens.
But I've stood up in the middle of a family dinner and left recently, where it's just like, oh, gotta go. And, out the door in the car and in the hospital 15 minutes later. Yeah. So you plan. You obviously don't, I think it only takes one time where you accidentally have to strand your wife and children in a park somewhere because you have to take the car.
Has that
over.
happened?
It's happened. Oh,
just get an Uber.
Yeah. Well, yeah, you have to plan of what happens if I get called. And plan for that.
When you do the night shifts, do you like them? Do you like the night shifts more than the day shifts? Is there a preference there?
So, I mean, we're not like staying in the hospital overnight. We're usually remote on call.
So it's only when you're
we'll be
operating
at home
there
and we'll be called in when there's someone who's very injured or who needs an operation. The trouble with that is, of course, you're still working during the day. So, you're there at night and sometimes you're sort of looking at your watch thinking, oh man, I've got to be back here in the morning in 3 hours time.
How do you deal with that?
That's the hardest part. I have to admit, the lack of sleep or the knowledge that you're not going to get much sleep is crushing sometimes, especially when you've been working really hard for a few days in a row. You're like, oh man, I just want to be in bed. But you just, like I said, you just work through it. And as I said, operating is actually quite easy and satisfying. So it's not the operation per se, but it's knowing that I'm going to be tired for the next 24 hours. It's tough sometimes.
Do you have any like secrets to get through? Like you'll just slam caffeine tablets or?
Yeah, I mean, coffee and caffeine is really very much an abused drug in my household. And I would tip my hat to anyone who doesn't drink a lot of coffee and decides they're going to be a surgeon. It's going to be tough.
Yeah, okay. Any other methods that you'll use to like stay awake or anything, or it's just caffeine purely?
Purely caffeine. Eating helps, but like if you eat too much, then that just makes you sleepy.
So like quick sugary snacks? Or?
Yeah, up and goes, lots of protein and some, not much volume. That's good. And lots of snacking. That's the real tough part is, oftentimes you're in the hospital and it's the middle of the night.
What's it like operating at night?
It's quiet. The hospital's much quieter in the middle of the night. And often you've got like staff members who usually work nights that you haven't met before. So it can actually be quite tough because
then you don't know.
You don't know them.
You can't gel and work in sync and stuff.
So, I've worked in a hospital for years and I know almost everyone very well. And then suddenly I'm there in the middle of the night and there's like 3 nursing staff who I'm operating with who I haven't actually met before or I've met maybe one time. But they're certainly not people I'm used to operating with and working with. And you sort of have to make sure that you're all on the same page and that, they know what they're doing and you know what they're doing kind of thing.
Yeah, right. And then I guess you could get pretty particular with like how you want to operate and they've got to know your style of operating as the surgeon.
Yeah, I mean, again, I think a lot of people would have a lot of criticisms for surgeons being very picky. I think.
But at the end of the day, if you're the one with the thing in your hand and like what you're doing can result in this person living or dying, like who I know it's like, who cares? You got to be a nice person to everyone else, but it's like, this is someone's life in your hands. Like you need to be like in the best state possible with everything working around you, how you want it to work so you can operate at your best because it's not them that's cutting into someone's abdomen.
Yeah, I mean, again, very blessed at the moment that I'm working in a hospital where all the staff is fantastic. But, you do, it's not so much picking your battles, but it's walking a fine line between this is exactly what I need. And it's less about, people having what you need ready, but having a knowledge of how long it's going to take to get the thing that you need ready. So sometimes, if you need a particular instrument or a particular, bit of technology, if it's going to take an hour for them to set up that thing that you need, then it's better to make do with what you've got. And also just acknowledging that, the nurses and the people in the operating theatre also are miracle workers. They can only do what they can do. And, in that situation, yelling at someone or stamping your foot saying, no, I need this thing isn't going to help. And, everything works better if you're working as a team. And so we have a regular team that we operate with a lot of the time, and they know what we want, and often they know what we want before we want it.
Cool.
So that's the benefit of, I guess, having this centralized trauma unit where, we deal with lots of trauma, is that we can set up that kind of system. And that would be terribly difficult in a small hospital where, you're not used to dealing with these things.
With all the news coverage and stuff, because it is the main one, like you have to navigate that. You do PR training, like.
We don't do PR training.
This is it.
This is it. Yeah, this is my training run.
Trial by fire.
It's not uncommon for again. It's not so much me, but it's sort of more the senior surgeons. But it's not uncommon for them to be out the front of the hospital giving a bit of a soundbite for the news, and it's just, I guess, something that they get used to doing. And you are we're all encouraged. I guess there's a difference between the news and the media, which can sometimes be almost kind of predatory, and outreach, which, I would view this more as outreach, which is, talking about education and sort of informing people what we do. We do a lot of outreach. We do programs with high school kids and all that kind of stuff to sort of educate them on what we do at the hospital and what sort of trauma surgery is like. So I've been trained and educated on how to do that. But it can be pretty confronting with reporters and things like that looking for sound bites. And we often have police officers who are looking for information. You have to be very careful about the information that you give out. And
to police officers as well.
Yeah. So, I mean, people have a right to privacy as well. So, we can't necessarily give police medical information without the proper legal channels being followed. So
yeah, right.
Yeah.
I wouldn't even think that. So like in terms of like police will come in and ask for all these details, like this is like client information I cannot disclose.
Yeah.
That would not be a nice conversation to have.
No, and there's been plenty of conflicts in the past and police officers who aren't very happy with that answer. But we have official channels, through the legal team and through the freedom of information and, patient consent pathways for police to get the information that they need, police and prosecutors.
Yeah, okay. And then in terms of like, and this was something I saw in the PITT, and then they said it's like a statistic that happens is like violence against workers in like the ER and stuff with like patients that aren't happy or something and will harm staff. Have you seen that?
Yeah, absolutely. I think it comes in lots of different flavors, I guess, is that there are patients who are upset, it's the worst day of their life, and the same for family members. And, we kind of understand that, people are not always in their best personality and best mood. We don't tolerate, people being violent and abusive as patients, but we also acknowledge that sometimes people might be violent and abusive because they're intoxicated or because they're injured, and they don't necessarily have the capacity to make their own decisions. And in those situations, it's very tough with someone's, violent, combative, got a bad head injury and they're very confused and they're lashing out. We have to sort of balance our safety and their safety at the same time. And there's also older patients who can get very delirious and confused, especially when they've had a head injury or maybe unwell. And then there's people who are just looking to cause trouble.
So how do you deal with it? How do you deal with that?
We have great security staff, right? So, I mean, we're all taught how to de-escalate sort of conflict.
Cool.
And so a lot of the time people are angry, and they might be angry for a reason because, they feel like no one's listening to them or they're not getting the care that they need. And so in those situations, you obviously de-escalating the situation by saying, well, look, hey, what's going on? What can we do? What's the problem? Why don't we sit down and talk about it instead of you getting angry and yelling and throwing things? But we also have security staff who can come and help.
Do you ever get like any bizarre like sort of requests or people that will come and say this person needs this or something, and it's like just the weirdest thing ever, and you're like, well, that just doesn't exist. Like,
Yeah, I mean, again, oftentimes it's just a misconception between sort of what's going on and what we do. And so a lot of the time, if something doesn't make sense because it wouldn't be what we would normally do or normally how we would treat something, we sort of just have to sit down with the patient and or their family who are sort of making that request and really drill down to like, what is it that you're asking for and why are you asking for it?
any odd ones that you could say or none?
Oh,
It's always when you ask on the spot. It's
I
tip of your
mean,
tongue.
yeah, a lot of it comes down, and again, it's not usually in the really acute phase because we don't really tend to mess around with things when it's like life and death and emergency. But there's lots of strange requests for certain kinds of foods and things like that. People who think that the only way that they're going to recover is if the patients are on a very specific, strange diet. That's
Any odd diet requests?
Oh, lots of odd diet requests.
Give me an example.
Juice diets, those kind of juice diets.
The
and
juice detox.
Yeah, juice detoxes and colon cleansers and probiotic shakes and all those kind of things. I mean, we have full-time dietitians on our staff who see patients, and certainly, everything that we do is evidence-based, and, we make sure that people are getting what they need, but it can be, very strange requests in terms of dietary requirements.
Oh no, I love it. I went to I had a shoulder surgery last year just across the road at St. John of God Subi, and like there was all these menus because I had an overnight shoulder surgery. It's like there's all these menus, all these meals I could pick, and I was just like, I tried to order like 3 breakfasts in the morning, like one after the other, and they're like, you've already had 2 breakfasts, you can't have another one. I'm like, my healthcare's paying like $2,000 for this. I want as much food as I can get.
Yeah, I would tend to say that maybe the menu options at St. John of God's is probably slightly improved from some of the public hospitals that I've worked in the past.
But it was nice. I got like a burger and some chips, and I was like, oh, I got to capitalize on this.
Yeah, but we try and accommodate everyone. I think nowadays there's always the endemic of different kinds of milks as well that are a problem.
Just drink regular milk.
So some people who might want various kinds of nut milks or non-dairy or lactose-free or soy, that can be a bit of a challenge. But our kitchens try as hard as they can. But sometimes we just have to say, I'm really sorry, we don't have that kind of milk. You can have a family member bring it in for you if you want.
Damn, I've actually got a surgery next week. I'm getting my septum is all crooked, so I'm getting that fixed up. So I'm going overnight next Wednesday, and it's like a rhinoplasty,
a
medical sarin something plasty, and it's like to straighten out the top of my septum, but then the bottom, because all my cartilage is on the wrong side, they're taking it out, straightening it up, and putting it back in. So instead of the typical half an hour like panel beater one on the septum, they're fixing it and then taking out the bottom, chucking it back in, overnight surgery. And I'm not looking forward to that, but I can't breathe properly lying down at the moment with my current septum. So I am looking forward to getting a good night's sleep.
Yeah, it's good. I remember many, many years ago when I was a junior doctor, I worked with some of the ear, nose and throat surgeons doing those kind of operations.
ENTs, yeah. Any tips for me?
Don't blow your nose afterwards.
I've been told I'm not allowed to for at least 48 hours.
Yep.
And I got to like this liquid I'm going to have to spray through my nose for a couple of months, and like I'm going to have splints in for a week.
Yep. Yeah, it'll be very involved.
Apparently my voice is going to change as well. I'm going to be a little bit nasally. I don't want that for the pod. Like I literally don't need my voice to change because of this. Like I hope it doesn't change for the worse, but
sure, they'll do a good job.
Yeah. Well, do you find people get really nervous to go like under for operations or?
It can be, yeah. So certainly, again, it depends on the type of surgery and everything like that. But it's one of those things that we have to navigate like case by case. People are worried about surgery, and you have to address what it is they're worried about. Like, are they worried about the risks? Are they worried about the outcomes? Are they worried about what maybe is going to happen in the operating theatre? And I guess at the end of the day, a lot of people, in trauma surgery and emergency surgery, they're worried if they're going to die or not.
What do you say if someone is like in a life or death situation, but they're like conscious, and they're asking you, and they're like, "Am I going to die or live?" Like, what can you even say? Like, we're doing the best we can.
Yeah, we're doing the best we can, and we have an idea, of course, of what the risks are, we're not going to offer a surgery if we don't think it's the best option. We all, and that's, I think, something that maybe sometimes patients don't get is, there's a lot of complexity and there's a lot of different options for things. At the end of the day, what we're saying that we think we should do, we're saying it because we think that's the best option. And it can be tough because sometimes, it's the best of a bunch of bad options. And sometimes
pick your poison.
And sometimes, one of the really tough things to navigate is sometimes the best option is to not do something, is to not do an operation because we think that it's, so dangerous or so risky that it's not worth it for the person. We call that, futility and futile surgery. Because at the end of the day, it's really not a nice thing for someone to die during a surgery or because of a surgery.
Yeah.
And if we think the likelihood of them surviving a surgery is close to nothing, sometimes it's better to not do that.
Oh, damn.
Mm.
That's pretty full on.
Mm.
Do you have like in the hospital like psychologists and stuff and people that will sit with you and talk you through this, or does
talk through us or talk with the patients?
You better have a pretty good EH program at work.
Yeah, there's a good employee assistant program in most of the hospitals that I worked in. But the reality is we have lots of tough discussions and lots of tough conversations all the time. And I think the most important thing is to be there for the patients and for their families because people have got a lot of questions.
Well, this is what I was going to ask. It's like when you're operating on these patients and stuff and it is life or death situation, and you don't want to like bring your emotion into it or your personal stuff and you want to be objective and like present on what you're operating on, like, do you build relationships with the patient? Like, can you like them?
Absolutely.
Does that make it worse then if you're like their life's in your hands?
Yeah. Sometimes it's tough. You sort of got to walk a little bit of a tightrope in that, and you find yourself, you're sort of flipping in and out of different modes. So like I'm in surgeon mode now, I'm doing this operation, and then like I'm now switching into, other kind of doctor mode, and I'm going to go talk to the family and tell them what's happening. And then, almost like a post-surgery mode where you're looking after these patients where, you're almost like a completely different person than you were when you first met them in the operating theatre. You're sort of, and sometimes patients are surprised because, you'll see them for a few days after their surgery and they'll be like, I just realised that I saw you like right before I had my operation and you did my operation. It's like, yeah. And they're like a different person, or I don't even recognise you. So I think they sometimes are surprised by how many different sort of hats we wear, and that we can be the person who's like saving their life in the emergency department or the operating theatre, and then the next day we'll sit down and have a chat with them about getting better and where the next steps are with rehab and things like that.
I think that's something the PITT did really well, was showing that versatility between, especially the main character Robbie, going from saving someone's life to going to like a waiting room and talking to parents about someone's life they've just lost, and then going back to saving someone else's life and then talking someone's parents through the options for their kid that's in critical condition. And it's like just constantly changing, and you're constantly having to like put on kind of like a different mask and be a different person depending on the environment you're in.
Yeah, absolutely. I remember watching that in the PITT and thinking that was something that they did really well. You see him sort of like, he comes out of a situation and he pauses, and you can see him sort of like build himself up to do the next thing, which, it's going to be difficult, or it's going to be a complete change in pace. And like it's true. Like, you have to be a different person for every different patient almost sometimes.
Oh, like, is that something you just, you get used to from doing? There's no really preparing for that?
I think everyone approaches it differently, and some people do it better than others. I think I do it well, in that I can sort of be what each patient needs in that particular time. And sometimes patients just need someone who's very sympathetic and like is going to listen to them and reassure them that things are going to be okay. And sometimes they need someone who needs to tell them like, no, this is what you need to do. You just need to tough this out, or, get up and work harder. And sometimes you need someone who's just going to be their friend. It's a different sort of mindset for every different person, and it can be quite difficult. Like often, you might get off the phone after having an argument with someone and then have to, completely change your attitude before you go on to the next thing.
Damn. Oh man, that's just so overwhelming. Like in terms of like education, because you say you do a lot of outreach in terms of education, like what's one thing you wish people like realized or knew about what you do?
One single thing.
Well, it could be a topic, it could be a theme in general.
Yeah, I mean, when I tell this to the kids when they're doing the high school visits, and like trauma surgery and trauma in general, but it's kind of surprising sometimes how many patients that we see in trauma surgery who are there because of, bad decisions. And I think everyone gets this idea that like most of trauma is like accidents, like, it couldn't have been avoided. But the reality is that like most of our road trauma, there's some kind of, behavior behind it.
Illegal
Behavior, either like speeding, drinking, drugs, or like, inattention, even sometimes, people on their phones, people falling asleep at the wheel. Like, we've even moved away. We used to call things like motor vehicle accidents, but now we call them motor vehicle crashes because, accidents implies that no one's at fault, when the reality is there's usually someone who's at fault. And so many of our injuries and patients who come into our hospital could be avoided if they had not been, not even them, it's someone, you might not be treating the person who was drink driving, you might be treating the person they ran over.
Yeah.
And so there's so many injuries that could be prevented just from people's behavior.
And that's like the number one thing you kind of preach.
And that's the number one thing, we tell people that, you can't control the truck's tire that blows off or the driver that hits you, but you can not be drunk, or you can not be getting into the car with a drunk person. You can be wearing a helmet when you're on your bike or your motorbike. You can make the decision not to climb up onto the outside of a building when you're drunk. And like the reality is that, I would say that over half of our patients are there because of those kinds of decisions. So you could half our work and you'd have a lot more people who weren't injured.
Well, I guess I know it's like, in terms of like, to me, for example, I would have no idea about all of this because I never see it in my life and I think it barely ever happens. And then to you, you're seeing it almost every single day. So you feel like it's always happening everywhere all at once. Like, where is that medium in between?
It's definitely between. It's definitely between.
Because you're literally living it and I'm a novice to it. But then it's like, it's happening, but how much is it actually happening?
Yeah, I mean, you can crunch the numbers, right? You can say there's 2 million people living in Perth and we have 5 major accidents a day and 3 of them are on the road. And we're saying 1 or 2 is because of drink driving or drugs or something like that. So that's 1 person a day that's getting severely injured out of, 1 million, 2 million people. So like still long odds, but, over a year, that's, 1 in 200,000 or 1 in 20,000. So your odds quickly come down. So if you're doing risky behavior or silly behavior all the time, then your risk is going up and up every time.
What's the casualty rate of people that come in?
So out of all of our major traumas, so those like 1,500 a year, the percentage who die is between about 5 and 10%.
So
about 100, 150 a year.
People a year.
Yeah, 2 or 3 a week.
And I guess, how do you deal with that?
It's tough. I mean, we have the great support network. We discuss every patient who dies.
Wait, sorry. Did you just say 150 years, so 3 a week, 2 to 3 a week?
Yeah.
So I just trying to let that sink
process
in for a
that.
second.
Yeah.
Yeah, far out. And you're there for all of it.
Yeah.
Sorry, back to my question. I just wanted to sink that in, especially for anyone listening, just so didn't gloss over it.
We discuss everyone who dies. We do a deep dive on their case. We assess like every part of their treatment and to see if anything could have been changed to avoid it. Oftentimes we come to the conclusion that there wasn't anything that could be done, like from a medical point of view. Sometimes we identify things that could have been done better, but wouldn't necessarily have affected the outcome. And sometimes we find something that absolutely might have contributed to them dying. So I think that's the other thing that people don't realize is that we take it all very seriously. You know, we investigate and assess, and that's part of that paperwork that I'm talking about. Is we investigate every death, every missed injury, every severe complication that happens to someone in the hospital, and we figure out why it happened and could it have been avoided, and what do we do differently next time to avoid it.
How do you go with that?
I mean, it's interesting. Like, you know, it's interesting sometimes to see why things happen and read into it. It's tough when you find something that doesn't add up, when you find something that like we could have done this better. It's, as I said, like a lot of the time we don't find anything. A lot of the time the injuries are so severe that there was nothing probably that anyone could have done. And at least then we sort of say, well, okay, hopefully we can sort of rest easy to say that we provided the best possible care for that person, for their family, the support, you know. So it's not just about necessarily saving lives all the time. It's about that person's life and their family's life, and to do the most we can to ease that for them. And we have lots of time that we spend with families, sort of, you know, helping them come to terms with, you know, loss and disability. And again, that's part of our treatment. You know, it's part of the treatment that we provide is for the families and for people who may have, you know, severe permanent injuries, is trying to ease that as much as we can for them.
Do you like what you do as a job?
Yeah. I think I wouldn't do anything differently, or I certainly, you know, if it was something that I wasn't enjoying, I don't think I have the personality to say I would stick with it if I was hating it. I recognize that there's good and bad things about it, but I think the good far outweighs the bad for me personally.
Net positive.
Yeah. And at the end of the day, I think as you go through, you start to realize that I'm genuinely quite good at this, and so I should keep doing it because I'm providing something that maybe someone else couldn't. You know, I'm filling a role that would otherwise go unfilled.
Nice. Something I do ask everyone that comes on this, and I promise it's not themed to our conversation before, is tombstones. Everyone passes away. Everyone gets a tombstone. Everyone gets limited character limit to have how they're remembered on their tombstone. What would you want on yours? How would you want to be remembered?
It's an interesting question. It's a good question. I think my view on this has probably changed over the years. And it sounds really cliche to say it, but like I think
no such thing when we're talking about this.
My focus in, you know, the last few years has changed immensely since I've had my own family, my own children. And whilst I recognise that the things I do for my job and for my work are probably impacting a lot of people's lives, the most important thing for me is my family. And so I think if at the end of my life I could have family that say that I was like a great father, a great husband, a great grandfather, that would be enough for me.
Awesome. Well, is there anything you want to tell people watching of where they can go for education or where to find stuff?
So, I mean, at the moment, so working at the Royal Perth Trauma Unit, we've got lots of stuff on our Royal Perth website about what the trauma unit does, our education links, our outreach programs. We have the PARTY program at Royal Perth Hospital, which is the prevention of alcohol-related trauma in youths. So we have visitors from high schools all around the state. And if anyone is in high school, they may have seen me over the last 6 months. But the PARTY program, we also do outreach. We also visit schools. And we also have programs where people can come who are not in high school and have the same sort of experience. If anyone's keen to follow a path in healthcare careers, like I highly encourage everyone. It's like tough work, but it's rewarding work, and you don't just have to be a trauma surgeon. There's so many different branches of the medical and, you know, allied health fields that provide like absolutely essential care for all our patients. And again, we would be completely lost if we were just a bunch of doctors in the trauma unit. We've got such a huge team of nurses, occupational therapists, social workers, psychologists, dietitians, speech therapists, everyone that make everything work. And it's I've never worked in an area in a hospital where that is so closely integrated, how we work so closely together. It's phenomenal. And so I encourage anyone, if anyone's in the health field or anyone wants to get into the health field, get in contact with the people who can make it happen. Come visit us at Royal Perth Hospital. Come work with us. We'd love it.
Awesome. Thanks so much for your time. I know you said you only get every second weekend off, so I really do appreciate you spending some of your Saturday here. This has been so eye-opening to me and so fascinating. And I really enjoy this. It's just like, and it's just the point of the podcast is like Crooked Smile, authentic conversations, not picture perfect. It's just like raw and unfiltered. And it's like, it's just so fascinating, just the whole world of like, and I really do appreciate you coming on and sharing that with everyone. And
yeah.
Some of it's pretty heavy stuff. So I do appreciate you coming on and talking about it.
Yeah, I'm happy to. And I think we've talked a lot more, I guess, probably not what I was expecting. We talked a lot more about like myself and I guess how it affects me and it affects me. But like, I wasn't even thinking about that before we came on. I was thinking you were going to ask more questions about like what it is I do day to day. And I guess you have, but you've asked it more about like, how does that?
Well, that's the human experience.
I love
it's
it.
What I just want to. I love understanding people's like worlds and what makes it work, but also how it affects them and how they navigate through it.
Yeah.
Like for me, that's that's the authentic version of someone. Like, yeah, these sort of conversations I just love having because it's just like, as I said, it's so eye opening. Like just like going day shift, whole night shift, next day shift, just doing that, like, and the toll it has on your sleep on a like over. Like chronic sleep deprivation over time is horrible. It's like things like that. It's like you saying the toughest part's like not getting enough sleep, or like part of the toughest part. Obviously, there's other tough parts. But it's just, man, I do appreciate you coming on and talking about it. I really enjoyed it.
I'm happy to be here. It was really fun. Thanks for having me.
Thanks for coming on.
All right, cheers.